Welcome to The Explainer. Today, we're going to tackle one of the most important topics for any healthcare professional, diabetes mellitus management. We're going to break this complex chapter down into a powerful study guide that you can use for your exams and, more importantly, for your practice.
Okay, so here's our game plan. We're going to start with the absolute basics, the two types of diabetes. Then we'll move into assessment, nail down the medications, cover what you need to teach your patients, and look at how to prevent those scary long-term complications. And we'll wrap it all up with an NCLEX challenge to really put your knowledge to the test.
First things first, let's make sure we are crystal clear on the fundamental difference between type 1 and type 2 diabetes. If you don't get this part right, everything else gets way more confusing. So let's lock it in. So what's the real difference here? Well, with type 1, think of it this way. Your body's own immune system has basically gone to war with the very cells that make insulin. It's an autoimmune attack. So you've got no key to unlock your cells for energy, period. Now, with type 2, it's a different story. The key is there, but the lock is kind of rusty. The cells have become resistant to the insulin. And over time, the factory making the keys, the pancreas, just gets worn out. Understanding this is everything because it dictates every single treatment decision we make.
All right, so we've got the why down. Let's dig into the what. How do these conditions actually show up in a patient? This section is all about recognizing those classic signs and knowing how to officially confirm the diagnosis.
First up is polyuria. So think about it. Normally, your kidneys are pretty good at holding on to glucose, but when your blood sugar is sky high, it's just too much for them to handle. The extra sugar spills into your urine, and it drags a ton of water right along with it. It's a process called osmotic diuresis, and it's exactly why your patient is going to the bathroom constantly. And, of course, all that urination is going to lead right to our second P, polydipsia. The body is losing so much fluid that it triggers this intense, overwhelming thirst. It's the body basically screaming for water to try and replace everything that's being lost. And this brings us to the third P, polyphagia, which is just a fancy way of saying excessive hunger. And this is the crazy paradox of diabetes, right? The blood is swimming with sugar, but without insulin to open the cell doors, the cells can't get any of it. They are literally starving in a sea of plenty, and they're sending frantic hunger signals to the brain. Beyond the three Ps, you have got to be on the lookout for these other huge clues. That weight loss, especially in type 1, is because the body has started burning through fat and muscle for fuel. And that fruity, acetone smell on their breath, and those deep, rapid breaths we call Kussmaul respirations, that's a massive red flag. The body's in a state of acidosis from breaking down all that fat, and it's desperately trying to breathe off all that excess acid. So how do we put all the pieces together and confirm it? Well, a finger stick is great, but it's just a snapshot. It tells you what's happening right this second. The A1C? Well, that's like watching the whole movie. It measures the average blood sugar over the past 120 days. That's why an A1C over 6.5% is the gold standard for diagnosing diabetes and seeing how well a treatment plan is working over the long haul. Okay, we can spot it, we can diagnose it, now we've got to treat it. And this next section on medications is absolutely critical. You will see this on your exams, and you will use this every single day in your career. This table is your best friend. Seriously, think of insulin in two ways, bolus and basal. Your rapid and short-acting insulins, that's your bolus, your mealtime coverage. It's designed to handle the carbs you're about to eat. Then you have your intermediate and long-acting insulins, that's your basal or background insulin. It works to keep glucose levels steady between meals and overnight. Getting this balance right is the whole game. Okay, everybody, listen up. This is a huge safety point and a guaranteed test question. Metformin and iodinated contrast dye do not play well together. They're both tough on the kidneys, and when you combine them, you're risking acute kidney injury and a really dangerous condition called lactic acidosis. Knowing when to hold and when to restart this med isn't just about passing a test, it's about protecting your patient. All right, we've talked about what we do. But honestly, the patient does 99% of the work. So let's pivot to patient education, because empowering them is the key to success. This chart is a nice, simple visual for nutrition counseling, but the real magic word here is consistency. Why is that so important? Well, because all those insulins we just talked about are timed to work with food. If a patient's carb intake is all over the place, their blood sugar will be too. Consistency is what makes the entire system work and prevents those wild swings. Now, this slide might look like just a list of do's and don'ts, but this is life-saving stuff. Because of nerve damage, a patient literally might not feel a small cut or a blister. And because of poor circulation, that tiny little injury can turn into a massive, non-healing ulcer that could lead to infection and even amputation. Every single point on this list is a deliberate step to prevent that from happening. So, we're doing all this work, right? The diet, the meds, the foot checks. Why? Why is it so incredibly important? Let's get into the nitty-gritty of what happens when blood sugar runs high for too long. Here's the bottom line. We're trying to prevent the absolute havoc that high blood sugar wreaks on the body over time. It's a slow, silent process that attacks the entire vascular system, from the biggest arteries down to the tiniest little capillaries. It starts with the eyes. Those super tiny, delicate blood vessels in the retina get damaged. They start to leak, they swell up, and that leads to blurred vision. And eventually, it can cause permanent blindness.
Then it goes for the kidneys. High glucose is like poison to those little filter units in the kidneys. Over years, it just wears them out, leading to chronic kidney disease and ultimately the need for dialysis.
And it doesn't stop there. It attacks the nerves, too. High blood sugar is literally toxic to nerve fibers. This is what causes that painful burning, tingling, and numbness, and it's exactly why that meticulous foot care we just covered is so non-negotiable.
And the big one, cardiovascular disease. Diabetes basically puts the process of hardening of the arteries into overdrive. It dramatically jacks up the risk for a heart attack or a stroke. That's why managing a diabetic patient isn't just about sugar, it's also about aggressively controlling their blood pressure and their cholesterol.
All right, let's pull all of this together and get you prepped for your exams. It's time to focus on clinical judgment.
Okay, you absolutely have to burn this into your brain. Hot and dry, sugar's high. Cold and clammy, need some candy. Let me tell you why it works so well. Hyperglycemia, high sugar, it dehydrates you, making your skin hot and dry. But hypoglycemia, low sugar, that's a true medical emergency. It kicks your body's fight or flight response into high gear. And what does that do? It makes you shaky, sweaty, and feel cold and clammy. This little rhyme could help you act fast and save a life.
And when you see cold and clammy, you immediately jump to the rule of 15. You have to know this protocol cold. Give 15 grams of a simple, fast-acting carb, like 4 ounces of juice. Wait 15 minutes, then recheck. Still low? Repeat the process. But listen, don't forget that final step, because so many people do. Once their sugar is stable, you have to give them a snack with complex carbs and protein. That simple sugar burns off fast. The snack is what keeps them from crashing again an hour later. It's just as important as the juice. Okay, here it is, your final challenge. Your patient's blood glucose is 52. They're lethargic, but you can wake them up. What do you do first? Let's break it down NCLEX style. A, recheck in 15 minutes? No way. That's delaying care when we know there's a problem. B, give a protein snack? Nope, that's for later. It won't work fast enough. D, report the findings? You will, but not before you intervene. The correct answer is C. You have to treat the dangerously low sugar right now with simple carbs. That is the priority. That's clinical judgment in action.